going to pop up. Cool. All right. Should we start? Okay. Can you all hear me? Can you hear me? Is this on? Hello, hello, hello. I'm having trouble projecting. Can you guys hear me? Just having trouble projecting because of my laryngitis. I had COVID last. Wow. Okay, that's really loud. Yeah, I had COVID last week, so my voice is not as strong as it usually is. Hey guys, we're going to talk about inpatient alcohol withdrawal management diagnosis today. We're not going to talk about outpatient management because that's complicated, and a lot of the management for alcohol withdrawal in the outpatient setting depends on kind of support staff and resources that we don't typically have. So it's a little bit beyond the scope of this. But I want to talk about diagnosis, the clinical course, and treatment options. A lot of stuff's probably going to be pretty familiar, but I think there's some things that maybe we should kind of revisit and think about and talk about that. I think we all have a lot of kind of assumptions, and the data is actually pretty poor for alcohol withdrawal management. So I think it's worth just acknowledging that and talking about it. There's just how common is alcohol use disorder? Super common is the short answer. About 14%. If you just went into the community and asked people and they told you the truth, it'd be about 14%, but it's way higher in the hospital, as you might expect. So up to 40% of patients who are admitted have alcohol use disorder. That's a lot. And then up to 30% have an alcohol-related health condition. So that's some complication, some sequela of inappropriate alcohol use. The burden of alcohol withdrawal syndrome, that's what AWS stands for. Half of people with alcohol use disorder, give or take, experience some withdrawal, and there's a huge spectrum of what withdrawal means, which we're going to talk about in more detail, of course, but about 50% will have some withdrawal, and about 20% of those people will have what's considered severe withdrawal, which is the thing we really worry about. And alcohol withdrawal is associated with increased ICU and hospital lengths of stay, hospital-acquired infections, risk of sepsis, and in-hospital mortality. So complicates admissions for people who come in for anything else if they have alcohol withdrawal during their admission. The pathophysiology of withdrawal is based on the chronic adaptation to high doses of alcohol over time. So with all addictions, there's behavioral and physiologic adaptation over time. And the two things that we're worried about with withdrawal syndrome, the physiologic withdrawal, not the behavioral kind of more addictive side, which we're not going to really talk about as much today, are based on the fact that alcohol is a depressant. So it both activates the GABA system, which is if you think about it, that is inhibitory. It activates that, so you have more inhibition, and it inhibits the activating system, the glutamatergic system. So you get less excitation. So the brain, to adapt to that, the GABA receptors become increasingly insensitive, and there's fewer of them. And then NMDA receptors increase in number. That's one of the chief receptors for glutamate in the brain, and become more easily excited. So the pathophysiology is based on this chronic inhibitory tone suddenly being removed, and you get uncontrolled excitation. And that's the pathophysiology is important. I'm not going to get into it any more detail than that, but the pathophysiology is important because that really depends on how you treat it. You want to treat the underlying pathophysiology. The diagnostic criteria for alcohol withdrawal syndrome, I didn't realize this. The diagnosis that everyone refers to is from the DSM-5, which I found surprising because alcohol use disorder, I get it. That's definitely within the realm of psychiatry and addiction medicine, but Alcohol withdrawal syndrome, I really thought would be more of a, strictly medical, but if you look in the literature, everyone refers you to DSM-5, at least for now. So as all diagnoses in DSM-5, they're like so annoying. It's like part A and then refer to part A, and you've got to meet certain criteria, and it has to impact quality of life, and et cetera. So I'm not going to read all these things, but I want to just point out a few highlights. So the first on part A is people have to be drinkers in order to have alcohol withdrawal syndrome. That's obvious, but the important things to remember is it's cessation of or reduction in the amount of alcohol they're using. So people might go into withdrawal and still be drinking if the relative amount that they're drinking is significantly less than what they typically drink. So it doesn't mean that people have to necessarily stop to have withdrawal symptoms. The second is that it develops within several hours to a few days of the last drink or reduction in their chronic drinking. So part of the diagnosis is recognizing the syndrome in relation to their drinking habits, but you have a huge range on when those symptoms can start. So it can start as soon as 6 hours from when there's been a reduction in the amount of alcohol that they're consuming to several days after their last drink. And I'll bring that up because obviously your suspicion needs to be high if you're going to recognize it potentially days after their last drink. The other one is that not attributable to another medical condition, another mental disorder, or intoxication or withdrawal from another substance. And that's to point out that a lot of the symptoms, which we're about to go over in more detail, are not very specific, and they could be from any number of things. So I want you guys to just kind of throw out some options, some ideas, other diagnoses that you might see that could be that you could see where you could see autonomic hyperactivity. Anything come to mind? First of all, what is autonomic hyperactivity? Tachycardia. What else? Fever. Sweating. Hypertension. Great. So what else might you see some of those things? What's that? I heard serotonin syndrome. Hyperthyroidism. Great. Sepsis. Okay. What about hand tremor? Increased hand tremor. Parkinson's. An essential tremor. This may be withdrawal of medications for that. Sorry.
So like
Hepatic encephalopathy. I thought I heard uremia, but maybe I just imagined that. Okay. Insomnia. When might people have insomnia?
poor sleep hygiene.
Poor sleep hygiene. Who knows? Okay. Nausea, vomiting. Everybody in the hospital. Visual, tactile, auditory hallucinations or illusions. What's the biggest one we see in the hospital? People have might have hallucinations. Just delirium of any cause. We're not even going to get into that. The differential is tremendous for that. Other things, primary psychiatric disorders, psychomotor agitation. Right. Okay. It could be anything. So it's pretty non-specific. And then we get into severe alcohol withdrawal. What does that mean? We're going to go through the kind of progression of the symptoms as they develop over time, but ATS has they had this convene this big working group of multidisciplinary, people from addiction medicine, critical care medicine, emergency, internal medicine, pharmacy, surgery. I forget all the groups they got together to come up with like a position paper for ATS on alcohol withdrawal syndrome. And it was both to give a summary of the state of affairs in the science, and then also to provide recommendations for future research and treatment. And part of the first thing they kind of came to is that we don't have great definitions even for what alcohol withdrawal is, or coming up with a working diagnosis. So, a couple decades ago, there's a big effort for what is sepsis, defining sepsis. You can't treat it unless you have a good definition for it. And now I think we all feel pretty comfortable knowing this is sepsis. We're good at recognizing that. But alcohol withdrawal and then severe alcohol withdrawal syndrome is still pretty muddy. So their proposed definition is a progressive state of central nervous system hyperexcitation due to reduction or cessation of alcohol use, resulting in severe signs and symptoms of hyperautonomia and hyperactive delirium. Not bad. Risk factors, there are many. I won't go through them all. The biggest ones are having had severe alcohol withdrawal syndrome in the past, a long history of use, and being older and being sicker. That's basically it. So the challenge as a diagnosis, as I'm trying to get it, is that it's not a very well-defined syndrome. Most of the symptoms are not unique to alcohol withdrawal, and they can mimic many things as you mentioned. There's no specific lab test that you can get to see if to really quantify how much someone's been drinking, or if they've been drinking recently, or if they're in withdrawal. It's often not the reason someone came in. They might come in with pneumonia, they might come in for an elective surgery and then not even have a history of withdrawal, and might not be anticipating it. You may not be anticipating it. And the diagnosis, as particularly given that it's a clinical diagnosis, depends a lot on the history. So if you don't know how much someone's drinking, or if they don't tell you the truth about how much they're drinking, it can be really hard to make the diagnosis of alcohol withdrawal very confidently. You guys can also jump in at any time with comments or questions. All right, so the symptom onset, this is a little graphic I put together. I'm pretty proud of it. I found this clip art. It looks like, I don't know, a bottle of whiskey or something. On the Y or X-axis is time frame, and then the Y-axis actually, there's no Y-axis, forget about that. So the first symptoms start around 6 hours at the earliest. That's when minor symptoms or seizure can develop. And that's from either the last drink or the reduction in the average amount that they drink. Hallucinations, alcohol hallucinosis can start at 12 hours. And then delirium tremens, the one we're most worried about, starts at 48 hours. So the total time course in general is roughly 4 days. But there's huge variability. It's really important to recognize the different phases and how they overlap, because a number of reasons. Not everybody has every symptom. They don't progress in an expected stepwise fashion for every patient. So for someone to have hallucinations on day, 36 hours after their last drink, say, they don't necessarily have to have had any symptoms prior to that to clue you in that they might be going into alcohol withdrawal. I also want to point out that at 24 hours, if someone's been 24 hours without a drink and they haven't developed any withdrawal symptoms, it's very unlikely that they're going to. So think about that. If someone's developing symptoms that you might attribute to alcohol withdrawal in the hospital, and it's been at least 24 hours since a drink or some other GABAergic medications, gabapentin or benzos particularly, and then they're now developing symptoms, say at day 36 hours, 48 hours, 72 hours, and people are saying, well, it's alcohol withdrawal. And if they haven't had any symptoms prior to that, you should really think twice, okay? Questions about this? We're gonna get into more details about each step in a second. No. All right, so the minor withdrawal symptoms, also pretty non-specific. So insomnia, tremulousness, mild anxiety, GI upset, headache, diaphoresis, palpitations, or tachycardia. Could be any number of things. Can be pretty, tachycardia can be pretty significant. Sinus tach up into the 120s, 130s, not uncommon. Moving into hallucinosis, usually starts around hour 12 to 24, usually resolves by day 2. Usually visual hallucinations, often for whatever reason involving animals or insects, occasionally auditory or tactile. What's important to remember for alcohol hallucinosis is that there's impaired cognition. Sorry, not impaired cognition, the opposite of that. Usually not associated with impaired cognition, usually normal vital signs. So when you're thinking about differentiating alcohol withdrawal symptom or syndrome from other things like a hospital-associated delirium or delirium associated with other acute illness, is to remember that alcohol hallucinosis itself is typically with normal cognition. So they might say, yeah, I saw some squirrels in my wastebasket, but they recognize that and they can tell you that and they're not otherwise altered. Blue mice and pink elephants is a quote from a Jack London story from like 1913, describing a particular alcoholic in a story who saw, or typical type of alcoholic who saw blue mice and pink elephants when they were in withdrawal. Does anyone recognize that pink elephant? I think Natasha looked like she did.
It's on the drink.
Yeah, so there's a Belgian ale called delirium tremens, and it has a pink elephant on it. But that comes, I think, early 1900s was when that term pink elephants was coined. But in the past, it was all kinds of different animals. So have you ever heard in something, seeing pink elephants, it's referring to alcohol hallucinosis. Seizures can start early, can be the presenting symptom, can be seizures. So as early as 6 hours, up to 2 days. Up to 30% of people with withdrawal will have seizures. That's significant. Possible risk factors are low platelets and potassium. And then there's something called the kindling effect, which I'm going to talk about in a little bit later. The seizures from alcohol withdrawal are typically brief, tonic-clonic, either a single seizure or multiple in clusters. Very commonly recur over time, but within this short time frame, very rarely progress to status epilepticus. It's possible, but not common. A brief aside on seizures: if it's someone's first seizure, you should treat it as a first seizure and not necessarily attribute it just to alcohol withdrawal. So that means they should get the full seizure workup generally. If they have a history of alcohol withdrawal seizures and have already undergone a seizure workup, they come in with alcohol withdrawal and they have a seizure, probably don't need to repeat the seizure workup. So this is, I don't know if you've all seen patients here where they come in with a seizure and they end up getting it's the first seizure and they end up getting a diagnosis of alcohol withdrawal seizures. I've seen that and I've been a little surprised that neurology would make that in this one specific instance. I didn't think the patient was high enough risk or didn't drink enough, but they felt confident. So it's a good thing to keep in mind if you have a new seizure, to always ask about alcohol history, and then also to treat it very seriously if it's the first time it's ever happened. And then withdrawal delirium is the one we worry about the most. So onset is typically later in the course of withdrawal, 48 to 96 hours, often in the last day, in the fourth day of that 4-day window that we were talking about. And it's also, I think, going to be really difficult to differentiate between other types of delirium unless there's the severe autonomic hyperactivity, but in its most extreme form is going to have what we call the tremens, which is severe drenching sweats, fever, tachycardia, hypertension, often with hallucinations. That's what can really get people in trouble. Mortality is associated most often with cardiovascular complications. But it can also just be an acute onset of fluctuating attention, cognition, and agitation. So really like most delirium syndromes, but usually more agitated, usually very abrupt onset, and potentially more severe than typical presentation of delirium in the hospital. Up to 25% of those undergoing withdrawal will have DTs. Mortality historically was up to 20%, but with appropriate treatments, only 1 to 4%. And then risk factors are withdrawal symptoms starting before the blood alcohol level reaches 0, prior history of DTs, coming in with a high CWAS score, so like above 20, older age, concurrent illness, or use of other sedatives. So if someone's also using benzos, some antiepileptics, gabapentin as an outpatient, they're going to be higher risk. Has anyone seen DTs in the hospital? Is it obvious? What do they look like? What's that? I can't hear you. Who's talking? Is that Jacob? The shake. Okay. Okay. All right. So
They look extremely uncomfortable.
yeah, extremely uncomfortable is fair. So I think it sometimes gets misdiagnosed earlier in the course of alcohol withdrawal. It's not the same as having tremors, which I don't think that's necessarily what you're saying, Jacob. But it's not the same as having tremors, which we can see, or tremulousness in minor withdrawal syndrome, or seizures. It's not the seizure. It's with this delirium concurrently. So the delirium is going to be there always, and severe dysautonomia often. So you're thinking severe tachycardia, severe hypertension, fevers, 103, 104, higher possibly. And it's later in the course, as early as 2 days out, but often 3 days out and after that. What's interesting about withdrawal syndrome is that any individual patient will tend to have a similar presentation each time. So patient A might have, very classic minor withdrawal symptoms of agitation and nausea, and then develop seizures, and then that's it. Patient B might not have any minor withdrawal symptoms and go straight to hallucinations and then DTs. Patient C, whatever, pick your description here. So asking people about their history when they come in is super important because it gives you some prediction of how they're going to present this time. If they've never had any history of seizures or DTs, that lowers your suspicion that they will this time, but it certainly doesn't preclude it. The greatest predictor for seizures or DTs is having had seizures or DTs, but not vice versa. So if someone's had seizures before, that doesn't necessarily put them at high risk for DTs. And if they've had DTs before, it doesn't necessarily put them at high risk for seizures. Withdrawal hallucinations and seizures can be the presenting symptom. Again, they can present without any minor symptoms of withdrawal. And then the first thing can be a seizure or can be hallucinations. But DTs are always preceded by some other withdrawal symptom. That's the exception. Everyone else can be that can be the only manifestation or the first before others, but DTs there will be something prior. What's tricky about that though is that if someone comes in for an elective surgery and they're sedated and intubated for a day, you might miss that window when they were going through the earlier symptoms, and then they might go into DTs after they're extubated and they're in the PACU or they're on the floor ICU after the surgery. So that's something to keep in mind, that it can be masked if there's some other reason why they're not able to manifest symptoms prior. Questions at this point? All right. Any other questions you would ask someone when they come in and you're concerned about alcohol use? What is your typical approach? Code status?
Yeah.
Why do you say that?
I mean, if they're seizing and they don't want to be integrated, you're not going to integrate them.
Okay, all right, code status, good.
Current medications, benzos, sedating stuff.
Great. So anything else that might either make them have higher risk of withdrawal if they have anything that's acting on similar pathways, or that you need to account for and give them so they don't go into withdrawal, you don't cause a withdrawal of a medication.
In previous withdrawals, details from
Good. Yep.
last drink.
Yeah, last drink. And how much are they drinking? Yeah. What else?
Sometimes I find what do they drink to be somewhat vague.
Uh-huh.
Say, yeah, I have 5 beers, but what they don't tell you is that they're all the way.
Great. Yeah, so that's a really good question. So asking how much is the first step, but then really asking for specifics. So what Sanders saying is that a drink isn't the same thing to everybody. And if someone's drinking liquor, it's usually good to ask them, if they say, 3, margaritas every night. If they're going out to a bar, maybe that gives you some confidence that it's, a relatively standard size drink. If they're making them at home, I have to ask them how many shots of alcohol are going in it. Does anyone know how many ounces are in a standard shot of alcohol, a single serving of liquor? 1.5 ounces. Yeah. So that's not much. That's not even a full shot glass. So most people are going to be if they're making drinks at home, if you are making drinks at home, I bet it's more than 1.5 ounces. Nope. I believe Terry. Any other questions you'd ask them? Yeah, Will.
So in my school, we kind of talk about like how there's like people don't want to buy their heavily drinking. So like one way to get a good number is to ask them how often do you go to the liquor store and what do you buy? And so that way you know exactly how much they're consuming.
Okay, that's a good one.
You get volume and frequency.
Yeah, that's good. I like that. It's a little more objective. Natasha?
This may not be as important as like the study that we're talking about, but asking about depression, feeling, anxiety. Psychiatric problems, and then also we don't really talk about family history of drinking, but there is like a correlation.
Sure. And what are you asking when you're asking about other psychiatric comorbidities?
I think like if there's an underlying reason for them drinking else that needs to be addressed.
Mhm. Okay, good. Anything else?
Something that does before the fast is trying to like figure out how much they're drinking. It'll be like, hey, how much do you drink? Is it like a 12-pack a day? Like starting with like a high number of something, and it's like, oh no, not 12-pack, just a 6-pack. Like, okay.
Good. So you're opening a window for them to say, yeah, 12-pack a day. Or to say, no, it's way less than that. It's similar to like if I ask people how often they miss their medications for like their antihypertensives, rather than saying, do you ever miss your medications? Like, no. Like, how often do you miss your medications? Just kind of normalizing it. So that's a good approach. I would also ask about co-ingestions, any other drugs they're using. Because you want to worry about overdose from other drugs or withdrawal from other drugs that might look similar or also need to be treated concurrently. And also, I think based on those numbers of how common alcohol use disorder is and especially how common it is in admitted patients, you really should be asking everybody who comes in the door about their alcohol use. Because again, they might be coming in for something elective or for some completely unrelated complaint. And if you're not anticipating it, which I think most of you guys do, it could really sneak up on you. So there's I don't have it in here, but something called Audit C is a tool to use to screen for unhealthy alcohol use. That's a really useful tool to just kind of either use or just kind of internalize and kind of use in part when you're doing an initial assessment on an admission.
Also has to be a stopping
Okay, why do you bring that up?
because they're different to, what makes you patients just go through their withdrawal in the hospital versus if they're just gonna go home and drink, or if you're planning on discharging them on like some benzos and then drink on top of that. I think it's just important to know.
Okay, yeah, I think that you bring up a lot of good points. So if someone, I think it helps you with discharge planning and safety and what medications you're going to prescribe. I think that's good. It might help with your timing of discharge if you want to hold them for a few more days to complete withdrawal, but they say, listen, doc, I'm just going to go home and drink tonight. Then that might change how you approach it. It's also not an opportunity. Someone might not realize they have an alcohol use disorder until they come into the hospital and you ask them about it. They might not have been ever gone enough time without drinking to ever go through withdrawals. They might not realize they're going to withdraw. So it's an opportunity to intervene and offer treatment in the outpatient setting for treating alcohol use disorder, which we talked about in the Wednesday afternoon didactics about naltrexone and stuff, and an opportunity to connect them to services. So yeah, absolutely. All right, so triage. ICU, if they need to go to the ICU for some other reason, obviously they should go to the ICU. It's a little bit less clear about who goes to the ICU with that just for alcohol withdrawal. I think you guys have some parameters that you're more familiar with, like CWA scores can trigger. I know in the order set, they score above 19, or they get more than 8 milligrams of lorazepam within an hour, or it prompts the nurse to prepare them for ICU transfer. Does that sound familiar?
Theoretically, but I don't know if that's.
Okay, yeah, and it doesn't need to be it's not a hard rule. Okay.
We just had one last night.
Why did they get transferred?
ICU
Was it recurrent or just the first score?
we admitted yesterday, and they were requiring high amounts of big, and because of that, got like reflexed into.
Okay.
John Austin was like, yeah, I think so.
Yeah, all right. That makes
This guy drinks like.
Yeah. So we'll talk about that a little bit more when we get into the treatment modalities, but that certainly makes sense. Other things to consider is so for currently high CWA scores after you've started treatment. So if they came in with a CWA of 20, you gave them some Ativan and then it was 20, and you gave them some Ativan and it was 20, that's probably means they're going to need a higher level of care and more aggressive treatment and close monitoring. If their symptoms start while their alcohol level is still elevated, that's a sign that they're at high risk for severe withdrawal. So that's one of the risk factors we know for GTs. If they have a history of seizures or delirium tremens, that's another risk factor. And then if they have other medical issues that are potentially could be worsened by the withdrawal. So an infection, if they're dehydrated or have an AKI, electrolyte or acid-base disturbances, significant heart disease. A lot of this can put a lot of pressure on the heart, the dysautonomia. If they're hypoxemic for whatever reason, that they might not necessarily for that medical issue require ICU admission, but if they're also going through alcohol withdrawal, that might prompt you to think more about ICU direct from the ED. Not a hard and fast rule, but just to kind of raise your suspicion. Treatment. So the traditional standard of care nowadays is symptom triggered using benzos. And so I think there's a lot of different practices here from what I've heard. What are some of your, how do some of you guys approach it, or have you seen it approached either on the floors? Particularly, let's just start with on the floors.
It's like more nurse driven than CWA scoring.
So you see a lot of CWA ordered and just PRNs?
Typically, and then some attendings will like order scheduled to bring, but different attendings have different opinions of how
Did you feel like you understand a rationale for scheduled plus PRN versus just PRN?
I think they view it as kind of like give them a baseline level of benzo, and then I think then you can activate it. Some of it too is if they're on the floor, you might be able to keep them on the floor with the scheduled delivery of, rather than having to transfer to the ICU.
Anyone else? Been a bunch of chatterboxes.
Doesn't the data show that placebo scoring patients receive a lot less benzos than if you schedule them?
It does, Margo. How would you say that? So there's this. Was that? So it does, yeah. So there's a study, well, I've mentioned it somewhere, in 1994 that using scheduled versus just symptom triggered, there's a huge difference in length of stay and total benzo requirements used. So it's like, surprisingly, I think the treatment duration for the symptom trigger was only 9 hours median, which seems really short. Whereas there's like 68 hours for the scheduled dosing, and it was 100 milligrams total benzo requirement for the symptom triggered and over 400 for the scheduled. So that was 30 years ago. That really set the standard for, it should be, symptom triggered is the way to go. That being said, there's a lot of caveats to that. So that's not always the right answer. Why are some reasons why you wouldn't be comfortable putting someone only on CWA?
And when you're staffing before they're on, you might not get appropriate grades.
Totally.
Scores in.
Yes, that's a huge one. That's something to really take seriously. They have, in order for CWA to work, you have to follow the protocol. And so we're in a huge staffing shortage now. The floors are understaffed, ED's overwhelmed and housing a bunch of inpatients. So if you're not confident that they can follow CWA, I think that's a reasonable, it's really reasonable to consider putting on schedule that first reference. Any other things? You're concerned about? What is CWA? Adam?
Very existential question.
It's really not. It's really not.
I don't believe it was ever meant for what we're using it for.
How do you mean?
I don't know. I just know that I've been told that it was not meant for inpatient administration.
Okay, it was developed for research initially, and it was, and then a lot of those research, the research studies were done at detox centers. And that's probably why the course of treatment was only 9 hours on the initial group, rather than what we see is usually days, because they were in less, they had either mild or moderate withdrawal and not severe withdrawal like we're most worried about. Yeah, that's true. Okay, so what else? So there's a systematic assessment of patient's status using a validated instrument at regular intervals. It gauges severity of withdrawal based on patient-reported symptoms and clinical signs. So patient-reported symptoms is a big caveat. So CWA, if you're familiar with it, not all of them, but many of these have a question associated with them. So nausea and vomiting, if someone's barfing in front of you, it's like, okay, nausea and vomiting, it's gonna get like a 7. But if they're not, you ask them, have you felt nauseous or have you vomited in the last 2, 4, 8 hours, however long since they were last assessed by the nurse? So they have to be able to answer that question. Anxiety, there's a component of asking the patient and observing the patient. All of the hallucinations, unless they're obviously responding to internal stimuli, you have to ask them, meaning you have to have a patient who can interact with you and answer questions appropriately. So you might have some degree of delirium in early withdrawal, not alcohol withdrawal delirium, like we think with DTs, that's a kind of a distinct clinical entity, but some degree of regular run-of-the-mill delirium early on that might preclude someone engaging in that kind of question back and forth. Using it at regular intervals, like Alex was mentioning, you have to have reliable follow-up with the nursing at those right intervals. It means you have to have nurses who are trained how to use this appropriately. So if you look at the CWA protocol for Erlanger, and it's based on all the ones that are out there, the frequency of scoring is based on the last score. So if they score between 0 and 7, they don't get any benzos and they don't get reassessed for 8 hours. If they score 8 and 15 or 8 and 14, they get 2 or 4 milligrams. and then they get reassessed in 4 hours. If they score above, I think 14 or 15, they get higher dose of benzos and reassessed in 2 hours. And you see, as they score higher, they get higher doses and more shorter intervals of assessment. So if you're not doing that appropriately, the scale doesn't work. You're not going to be able to safely manage it if you're not using the scale appropriately. I've also seen people get Ativan for anxiety when they're on CWA, when the PRN order specifically says the CWA score above a certain threshold. So if your people administering a PRN medication are not following the PRN indications, you might say like, oh man, they require 10 milligrams of Ativan in the last 24 hours. But if you don't know what they actually scored on CWA and what the indications for those doses were, you might over or underestimate their actual requirements based on withdrawal, the alcohol withdrawal. Okay. Another problem with CWA is I think we often, and I've done this too, use it as a diagnostic tool, which it's not. It is not a diagnostic tool. The diagnosis, like we were talking about earlier, is really based on the history and then the findings that were in that DSM criteria. So I know I did this as a resident. I was at the VA. I was meeting someone right before shot sign off. And there's a higher incidence of alcohol use in the veteran population. And I was like, I just got a suspicion about this guy. He didn't admit to alcohol. I'm just going to throw on CWA. And overnight, he required a bunch of benzos. And I felt pretty proud of myself. And I might have been right. I don't remember. But I was thinking about this recently. He might have gone into alcohol withdrawal and I didn't catch it and it was helpful. But if I put that on and I don't actually know if he's going to withdrawal, and we know alcohol withdrawal can look like a bunch of other things, and then he just starts getting benzos, are you misidentifying the syndrome and treating it inappropriately? Was he having a heart attack? Was he septic? Was he having delirium from some other cause? Was he withdrawing from some other drug? So I caution you against using it as a diagnostic tool. And if I've ever done that with you, I'm changing my ways starting today. All right. So all of these criteria, all of these 10 points on CWA are scaled on 0 to 7. So I think the maximums, except for number 10, which is a 0 to 4 scale. And I think the maximum score, 67. And so it's good to familiarize to know what this looks like and know where to find it in Epic. Don't ask me where to find it in Epic. I still can't, but we should figure that out together. Because again, knowing what people are scoring for, if they're actually scoring high enough to qualify for benzo, and then looking at how many benzos they've gotten is really important for getting a sense of how their withdrawal is progressing. It does, but what they actually recorded over time is what I'm talking about. So the nursing like charting, I don't. So the point of symptom triggered is to give patients what they need only when they need it. And as that's pretty good with those numbers. Margot said it is associated with a shorter length of stay and lower total benzo requirements. There's something called front loading, which I think is a really important notion. Front loading is getting people rapidly down to a target CWA score of usually around 10. So if someone comes in like Nick's patient last night with a CWA of 20 or whatever, giving them high doses of benzos in rapid succession to try to get them under control might end up making them end up in the ICU very well, but is associated with a shorter length of stay and better outcomes than if you don't rapidly bring them under control. And that can mean really high doses of benzos up front, higher than we're comfortable with. And if it's more than 8 in an hour of lorazepam, they should be in an ICU setting because there's risks associated with benzos. There's limitations, as we talked about. It's not a diagnostic tool. It's labor intensive on nurses. It's also a pain for them to do that, especially if they're short staffed. Not to say that they shouldn't. If it's appropriate, they should do it. Heavily patient reported symptoms and is pre-subjective. I've had nurses on the day when I asked them how the patient did overnight. They're like, well, they were just asleep all night. And I said, well, did they score really high on CWA? They're like, well, the night nurses scored really high on CWA. And that was, someone's jaded report, but there's some subjectivity. If someone wants someone to sleep overnight, they can probably come up with reasons to get them high enough CWA score to sleep and have them sleep overnight. Why do we use benzos? They work for the most part. There are some limitations. Benzos only if are GABA agonists. They do not affect the glutamate system at all. So part of withdrawal is You no longer have this chronic activation of the inhibitory pathway, the GABA pathway. And then you suddenly remove the inhibition on the excitatory pathway, the glutamatergic pathway. So with benzos, you're reactivating GABA, calming things down, but you're not attacking the glutamate side of things, the NMDA receptors. GABA receptors also become downregulated in their sensitivity over time. There's cross tolerance, so they might be resistant to benzos. And then benzos are not the safest thing. You know, people are going to tolerate them a lot better with chronic alcohol use, but there's dose-associated somnolence, respiratory depression, delirium, and mortality. Let's speed up a little bit. So most sources that I read prefer longer acting benzos with active metabolites for alcohol withdrawal. And that means in general, Librium and Valium. Drawbacks, there's no IV formula of chlorodiazepam epoxide of Librium. They're both metabolized in the liver, so they're not good with patients who have ALK, HEP, or cirrhosis. And then just for your reference, it's about a 5-to-1 equivalence for dosing for diazepam to lorazepam. So just keep that in mind. If you're more comfortable and familiar with dosing Ativan, and you're switching to Valium, 1 milligram of Ativan is about equal to 5 milligrams of Valium. Ativan and Serax are alternatives. Ativan's shorter acting and doesn't have active metabolites, but are safer for people with liver dysfunction. You may have noticed that the PRN order in the order set is only for Ativan. And I don't know why that is. There tends to be better outcomes with longer acting active metabolite drugs because it just provides a smoother withdrawal. So you're not getting these spikes. So you think about it when treating pain, you're not chasing it as much. You're just providing, if you provide long acting drugs. So I don't know what to tell you. There's no way to order PRN, CWA, Librium at this point on the order set, as far as I can tell. But this is what's recommended.
Quick question.
Yeah.
Sometimes, for better or for worse, the ICU, or let's say somewhere else, a provider will be really worried about doing Ativan and just say, oh, just throw Precedex on. How do you feel about that? Because sometimes I feel like I've looked it up and there's not really any data for it in preventing withdrawal. And I feel like it worries me more because it masks a lot of the symptoms. And will allow it to
Totally agree. We're going to talk about that in a minute. Special considerations with patients with delirium. If someone's delirious, they can't engage with CWA, so you can't use CWA anymore. So you need to use an alternative options. There's no standardized approach. I think here, I don't know what we use. How do you guys dose in the ICU if they're delirious or if they're intubated? What? Just go by RAS, which is fine. That's an option. Or CAM ICU. Those are fine. So things that have more objective measures, you're basing it on the sedation and less on their reported symptoms. The goal is light somnolence. I'm not sure how sedated you guys are, patients in the ICU, but probably RAS of -1 to -2 is better. They're able to awaken and make eye contact with you, but they're going to fall back asleep. And just remember that IV lorazepam and Valium can cause metabolic acidosis. Does anyone remember why? Bonus points. What's the solution that they're in? Tina? Propylene glycol. So you can get propylene glycol to this thing. All right. Other special considerations, if they're still delirious after 2 to 3 days, maybe back off on the benzos. You can get a benzo-associated delirium and you can start using alternatives to treat the delirium. So antipsychotics or phenobarb. And according to the American Society of Addiction Medicine, Precedex should not be used specifically for alcohol-associated delirium. So just to wrap up, some treatment adjuncts. There's some good data for phenobarbital as an adjunctive therapy or as monotherapy. One of the benefits of phenobarb is that it targets both the GABA side and the glutamate side that I was talking about. So if someone's either resistant to the GABA because they have just too much tolerance or the kindling effect, which I'm going to talk about in a second, that's something to consider. There was one study actually done in Nashville with St. Thomas West, which is our partner, UT Nashville, and Vanderbilt folks that used phenobarbital. They did a retrospective cohort study, but they had a phenobarb protocol in their ICU that was a scheduled dosing and was a fixed dose rather than weight-based. And they had short of ICU length of stay, hospital length of stay, and incidence of mechanical ventilation. And those numbers are pretty impressive and they're all statistically significant. And there are protocols here. So that's not something we're doing now. We do have phenobarb in the ICU. It's, I think, mostly, I think there's both a one-time dose and a PRN dosing. And I think it's going to be largely dependent on the comfort of your attending. And I think it's only IV and they have to be intubated, but I'm not totally sure. But something to keep in mind, bring it up on rounds. So Precedex, Tanner brought up all of my concerns with Precedex and a lot of concerns you see in the literature. So again, when you're treating alcohol withdrawal, you have to treat the underlying pathophysiology, which is this dysregulation of the GABA and the glutamate system in the brain. Precedex is not involved in either, and it helps masks dysautonomia and agitation without actually treating the underlying dysfunction. So there have been small studies that using Dex, I can't pronounce that, Precedex as an adjunct to benzos can lower total benzo use and mechanical ventilation incidents, but there's safety data concerning risks of hypotension and bradycardia. And if you're underdosing them with benzos, because they don't look as, the withdrawal doesn't look as severe as it actually is, you might actually precipitate a seizure. But it's used all the time here. So I caution you, it has a place, and I think the toxicity of benzos are real, and that's a good argument for Precedex. From what I've read from the Society of Addiction Medicine and ATS, really the recommendations right now are more, first of all, there needs to be better studies because they're only small studies and they're underpowered and hard to generalize. But to use it more to focus on the dysautonomia associated with alcohol withdrawal, not delirium or seizures. So if they're otherwise generally calm, but they're having this extreme dysautonomia and you think they have adequate benzos, you can use Precedex as an adjunct. I've heard anecdotes about people not getting their doses of benzos because they're hypotensive. Why are they hypotensive? Probably because they're on Precedex. So if the Precedex is getting in the way of you giving them the definitive therapy, then you need to back off on the Precedex. Precedex does not take the place of benzos or phenobarb. It's only meant to help you reduce the total amount that they need. Does that make sense?
And just Precedex on our patient right now, but we like clear communication with the nurses to use the other first and then on top if you need the Precedex. It's not just put it in and walk away.
Okay, I think that's reasonable. I think, it may be, I don't know, it seems like it gets used really early on too. I think it probably, we need to give the benzos a little bit more of a chance. If you're not seeing if you're not really concerned that they're resistant to the benzos, and you're not seeing any consequences from the benzos, then why add Precedex? It's just one more thing to keep track of. And it's
For the most part, I haven't been used, but what I've seen is the night nurse uses it a little bit more than it turns out as soon as they go.
interesting. Okay. So if patients are failing to respond, if you're going escalating doses of benzos, consider just using higher doses. You might be underdosing them. People can require hundreds of milligrams of benzos, at least of Valium, and up to 100 or so of Ativan. That's not unexpected, but they need to be in a monitored setting. And if they do, then consider transferring them to a higher level of care because they need to be monitored for the toxic effects. Consider switching to a non-benzo-based regimen. That really means phenobarbital. There's some times using valproic acid or gabapentin as monotherapy. That's not something you're going to do inpatient here. I think that's more of a detox center. And then the kindling effect, it was worth mentioning, is that as people go through repeated withdrawal, the risk of having severe withdrawal, of the severity of withdrawal getting worse, each withdrawal is higher because there's toxic effects on the brain from repeated alcohol use and withdrawal, and they're higher risk for hyperexcitability, seizures, etc. So understand that they tend to have a similar presentation each time, but the severity of their presentation, they're the same symptoms, but the severity of the symptoms tend to be worse. Not in everybody, but often as time goes on with recurrent withdrawal. And then consider adjunctive therapy, Precedex, phenobarb, etc. Okay, blah, 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 blah. Just some things to think about with the order sets. Again, only lorazepam for some reason is available. I don't understand why. thiamine, folic acid, multivitamin are all optional. I think they should probably be default to use them for everybody who's coming in with alcohol use disorder, alcohol withdrawal. So I would just encourage you to order that on everyone. And the dose of thiamine is only 100 milligrams. If you have any concern for Wernicke's, do the treatment dose, which is the 500, 250, 250, et cetera. Antihypertensives are an option on the order set. I would caution you about that because they might, clonidine is just basically an oral Precedex, and metoprolol might mask some of the symptoms of withdrawal and make you underdose the benzos. Antipsychotics are available as an option for delirium and agitation, even for floor patients. I also caution you against ordering that without really considering it and reevaluating the patient. They might develop, again, concurrent delirium that's not directly related to an alcohol withdrawal delirium, but you don't want the nurse to just give them Haldol when they really need higher benzos and maybe transfer to the ICU. Maybe they're going into DTs and Haldol is not the treatment for DTs. Questions about that? Okay, last thing. Why not just give them alcohol? I feel like this comes up all the time here with you guys. This is actually a screenshot from Adam's first day on the floor. I caught him. He was about to order whiskey drink and beer can on a guy, and I had to stop him. So what is the role for alcohol in the hospital and for specifically with alcohol withdrawal?
Somebody's just going right back out in the area and they're like, having to go through the withdrawal. If they're not like quick, then there's something going on.
Another good thing about that. Now, like I said, we're just gonna go out and start drinking again anyway.
Kind of like letting someone smoke while we're at the hospital. We don't let that happen.
Yeah.
Another issue is,
What's that?
I was gonna say, there's no predictable dosing, so there's no way to actually treat symptoms. They just drink till they feel better, but I think it's more unpredictable in terms of the metabolism.
So they're gonna drink more of the alcohol, so why control sometimes?
Or I have a question, like, is there the same, I don't think there's the same level of hepatotoxicity with alcohol versus benzos, right?
So an argument against that is potential toxic effects of alcohol. So on the GI system, liver, bone marrow suppression, dehydration, and then I think dosing is really tricky. It's not a bar, so you can't just have a patient order. You know, that's just, I think it's putting us in a pretty awkward position. Any other thoughts? I want to give you guys a chance to talk.
I'd say one of my reservations about it sometimes is when someone's like, yeah, I drink 2 packs of beer a day. And I'm thinking, okay, if I just give them like 1 can with every meal, that's not gonna be enough for some. So when someone's on really high alcohol tolerance, I'm not gonna give them 6 cans. Particularly when I can always. And I only order take it.
Yeah, so how do you know, it's hard to titrate, if you're gonna, are you trying to keep them out of withdrawal, or what, they're drinking that much, so they really safely give them that much alcohol. Effects is different on those guys, so so I think this idea also, if they're just gonna go out and drink again, yeah, that's true, and I think to, Steve was talking about earlier, it's important to ask and to engage and to tell people, hey, I think you're drinking too much. This is why, here's the recommendations. This is the first time I've gone through withdrawal. It's an opportunity to say, hey, you stuck in for a day or two, you felt it. It's not happening before. It's really getting to reflect. You should give everybody the opportunity to get treatment, to get recovery, support, hope that this can be dealt with in a non-judgmental way. Saying others, say that's what you're saying, exactly. I feel like it's kind of saying, well, it's not our problem. Either we don't recognize this as a problem that we think is fixable, or we don't care, and I think that sends a message to, we don't have patients smoke in the hospital. But yeah,
you have to, you're telling them, shouldn't smoke, you know? If you're taking to excess, you're drinking from that withdrawal, you need to tell that. That's a chance to really talk to them. Amazon, a patient she had recently, was a consults who wanted alcohol in the hospital and started like getting hydrated, started getting belligerent, he was drunk, and it's just like, you know, just. I don't think there's anything in other hospitals we all look at that's so alcohol. I was floored when I saw that. I was talking to a colleague and I mentioned it, he's like, so, he's like, couldn't believe it. So it's not common practice.
That patient was actually like very confusing to me. He was the NP that was seeing them and he was stage 4 cancer and getting scheduled alcohol, scheduled Librium, adding in PRM, so a bunch of things just to like see how much he's doing, but then the NP we just keep saying he has stage 4 cancer, he's gonna go drink. We're like, "Can you talk to people about it?" And then finally he's like, "Yeah, I have cancer, I don't want to drink anymore." So it was very strange.
I think there's an ethical dilemma too, like I can see an argument, well, you know, if they're gonna drink anyway, but on the other hand, while they're here, we were talking on the GI service today about how almost every week there's new people, especially women, it seems, under 40, under 35 years old with alcoholic cirrhosis. You're just feeding them while they're here. That to me seems like, you know, what are we really doing? I understand there are things outside of our control, but
Yeah, what's the message?
yeah, exactly.
We see this as a,
Keep killing your liver while you're doing all your beer.
we're gonna give you medication to help you get through this withdrawal, and let's talk about
And then it's up to, then it's up to you what to do with it, but we're gonna give you every sort of
opportunity.
involuntarily.
Michael,
Drinking is their choice, not deciding to make them withdraw in a hospital, that's making a decision.
sounded really good.
I was saying that I think that smoking and drinking, I think that's a false equivalency.
I heard that part. I think that's fair.
And I think ethically, I don't feel that I should be making the choice for the patient that they should drink. Withdrawal is a dangerous process, and me deciding in the hospital that they're not allowed to, I feel like I'm making a decision for the patient. Not for me.
While they're in the hospital for some other reason. Well, you can understand, you're saying they can't drink water here. And I think there's medical reasons why that's a fair decision to force them. If they say, I don't want my hip replacement because I want to drink, you say, I can manage your alcohol cravings, withdrawal while you're here. And you can, whether or not you think that leads your choice.
And is the risk on the back end if somebody gets used to drinking heavy amounts of alcohol from the hospital?
I'm not familiar with that as much. There's definitely a problem with opiates. I haven't heard about that with alcohol. So there's this very serious issue of people getting discharged from rehab or leaving prison after detoxing from opiates, they all really high tolerance and go back. So it's going out heroin and they overdose die because they have no tolerance. I haven't heard about people say like overdose from alcohol. Oh, it's possible. I'm so really but I caution the libertarian view of like, who am I telling you want to drink in the hospital? You're not about drinking, your judgment during hospitalization. But it also counts. You can't tell them what to do, but you can tell them. I strongly advise you to stop drinking. Start treatment.
Not to belabor, but if you are prescribing medication they're abusing, you know that they're, that's again an ethical or dilemma. Yes, their choice, but I can't, as a provider, I can't enable something that's killing them or killing a family member. I kind of see this the same way.
Yeah.
Well, we give them bacon. Give them French toast.
That's a whole other one. We gotta run that wrong now. Anyone else have to say? You done? You guys want to see a baby picture?
That's the last slide. Thanks, guys.
Very good.
That's all right.
They've been sitting behind you.
I'm like sweating and my nose is just